our research program is slightly different from the previous speakers because we are really focusing on establishing capacity. So I'm going to be touching upon multiple areas and just giving you a snippet of what can be done and what's the potential, but also, think of the opportunities that can be translated. How can we translate this to other diseases? And although I'm a cardiologist, I actually think about chronic diseases as a whole. And I believe that we use only a very, very small portion of the data that we have. So while, we need to collect more data that are very specific, we are not even using the data that we have currently in our electronic health records. So hopefully I will convince you from macro to micro today to, although I say cardiometabolic disease or insights here, this is really applicable to all variety of different diseases, from dementia to infectious disease to TB to everything else. So we, just as a background, as clinicians, we're trained in looking at, the organ that we're studying. So for example, this is from medical school. We focus on the heart, we focus on the vessels, we focus on everything else that comes anatomically close to it. And we started to kind of get a little bit closer to the population, to the risk factors. So this is what we call the American Heart Association Life Simple 7 or Essential 8, where we start to focus on other things that may not be anatomic, but risk factors. So for example, behavioral, quit smoking, sleep better, eat better, and so on and so forth. But I would argue that there is actually a whole lot of other information that we're missing that is existing, available to us. Every time we open Epic, for example, which is our electronic health records, we see an address of the individual, and we have no idea. We know that there is a lot of information in that address, but I have no idea how to translate that to actionable insight. So that's one. Number two, as an opportunistic part, we really do quite a bit of these screening tests, mammography, colonoscopy. And from the cardiovascular standpoint, we really think about taking a picture of the heart. And this is a picture of the heart. This is something called a calcium score. This is a test that's almost like an X-ray that you can get for $100 out of pocket. And it gives you a whole lot of information. But what we're realizing is that these risk factors that we investigate in individuals, diabetes, heart, family history of heart disease, blood pressure, they don't necessarily translate to the biology because it's not a linear relationship. So this is an example of a couple of patients in my clinic, 35-year-old who has no traditional risk factors, no diabetes, no lipids, no family history, and we decided to do a CT scan, and you can see that there is a significant amount of plaque. This is a plaque that's equivalent to somebody who is 90 years old. While we have a 75-year-old who has everything under the sun, high blood pressure, diabetes, and they really have no plaque. So what drives this susceptibility on the left side and what drives the resiliency on the right side is really the big question that we're trying to answer. But obviously, the methodologies that we're creating are applicable for a whole lot of variety of questions that we can answer. And what is intriguing when you start to look at cardiovascular mortality or any type of mortality across the United States, there is a tenfold difference between the highest county and the lowest county. And whilst there are some structural issues that are related to access to care and so on and so forth, there may be some very, very tiny genetic component to this. Tenfold is not explained by this. So there's a lot of other things that are outside our bodies that are impacting us that can drive this what we call stroke belt or cardiovascular risk belt and so on and so forth. But there is a tenfold difference in that. And how can we understand this without interacting with the patients? How can we leverage the millions of data sets that we have at our disposal to understand this differences in resiliency and discrimination? So I'm going to start to help you think about disease, although I say heart disease here, but really every disease, from the context of everything around us, the environment, neighborhood effect, to the organ, to the cell level, right? So this is not a very high-focused vision that looks only at the coronary artery and understands the plaque buildup and so on and so forth, but really taking that in the context of everything around us, but everything inside of us, right? And how can we make this framework pragmatic without going and putting sensors on people, without going and taking a single cell sequencing, and that is tremendous, gives us tremendous information, but again, it does not translate to millions of patients that we have. So how can we bridge the gap between population health and individual health using this pragmatic data framework? And hopefully I'll start with giving you some just examples of what can be done across the board, because we're doing work across the entire spectrum, all the way from populations to cells. And I'll give you some examples of what can be done and also show you, some of the applications. So from an environmental kind of exposome, exposure assessment, we don't live in isolation. We live in the context of what we are exposed to. So everything that I show you here has been either causally or consequentially linked with cardiovascular disease and other types of diseases as well. So noise, light, at night, artificial light, temperatures are huge determinants of health. Air quality, I don't need to convince you about that. Green space and other things like socioeconomic status. And this is integral part to the bottom things, which can really, the microbiome we heard the other speakers talk about, the genomics. We also have some wearable data that's incorporated. So this is the whole framework that we need to start to think about. And from an environmental standpoint, every patient has a zip code. Every patient has an address. So what we've been able to do is we started to hypothesize that your environment, your neighborhood, has a lot of information, and it can create fingerprints for very specific diseases. So in this thought experiment, what we did is we took about 1 million images from satellite imagery and street view imagery, and we looked at around 600 neighborhoods in the United States across 7 cities, and we asked a simple question. Can we take these images and extract information from these images related to how many trees, what type of cars, how many streets, what's the crossroads, and so on and so forth, in deep fashion using artificial intelligence? And let's link it with neighborhood health effects or neighborhood health indicators. And in this scenario, we took coronary heart disease, but we have other analyses that looked at obesity, dementia. We've done it in different health conditions. And what we see is striking, because 60% of the variance that I showed you earlier of that tenfold difference, 60% of that can be explained by things that we see on satellite imagery and street view imagery. And that's powerful because it tells you that neighborhood effects that are ignored to this moment really have a tremendous opportunity. So now we have, in addition to this, we have incorporated this with clinical risk factors. And what we see in early studies that when you look at Houston Methodist patients, for example, we have approximately 2 million patients, the information that's extracted from these images enhances risk prediction for various conditions, including dementia, including psychiatric illnesses, and so on and so forth. So this is, again, work in progress, but it shows you the linkages between computer vision, environmental health, but also and health outcomes, but it also helps us really integrate across disciplines. This is not just a health metrics. This is touching upon urban design. This is touching upon city designs and community design, and so on and so forth. So there is, we have a lot of collaborations now with multiple schools and scientists that focus on urban design and trying to integrate health outcomes, predicted health outcomes, in a context that you can generate a digital twin for your environment that can link environment with health outcomes. And I'll show you examples of the work that we're doing with RISE around that. And some of the additional exposures, although I showed you an example of satellite imagery that we have in street view imagery, there is a whole lot of other information that's embedded in that geographic address that we're starting to study. So for example, there's data on tracking cell phone movement for individual populations. So we know not only where you're exposed to in your neighborhood, but also what you're going to. So we can actually quantify the amount of green space that you're exposed to. We can quantify the amount of which park you spend your time in. We can quantify which neighborhood you go to HEB, and also by indirectly quantify what type of purchases are you making. Of course, there's a lot of privacy issues, but this is at the population level. This is at the nutritional level for a whole neighborhood. So we also have data now that to start to investigate not only static measures like Google Street View, but we're also looking at temporal measures. And we know, for example, for Houston, heat and cold are very, very critical determinants of health. And this is the curve that you see in the lower corner. This is actually from about 40,000 patients that had a heart attack at Houston Methodist. And what you're seeing on the x-axis is the temperature. And we have a minimal temperature where we don't get heart attacks. But then we have on the extremes of temperatures, both high temperatures and low temperatures, we have a significant increase. This is not a minimal increase. We're seeing 30, 40, 50% increase in the number of heart attack events that happen when you compare the same patients to periods that have different temperatures. This is accounting for seasonality and everything. So this is a true association that has a biologic plausibility that we're trying to investigate. On the right side, what you see is that we also have a partnership with a company that has a very high resolution drone images. These are kind of oblique images of the neighborhoods that gives you a little bit of the micro environment, so to speak. So instead of the 30,000 foot view of the satellite imagery, we also have data now on the types of trees and so on and so forth. And using computer vision applications, you can actually segment the pavement, you can segment the type of car, you can identify trees, and then you can quantify their relationship with health outcomes so that eventually, hopefully, we can actually render a neighborhood the design, and we can impute or we can infer how much heart disease or risk of stroke that's going to happen in this neighborhood. I'm going to show you, and this is, again, just is a small snippet of what we're doing, but there's a lot of pipelines that are really along that framework of the exposome. I'm going to shift gears a little bit into a little bit more a phenotypic understanding of disease, which, again, it builds upon the exposome, but it's really it requires a whole pipeline of its own. And I showed you these examples of these CT scans that you can get really across the board. Methodist offers them, again, around $100 or so. And these are done, the nice thing about them, they're done in healthy people who have not had a heart attack yet. So it gives us the sweet spot of detailed information because it's a CT scan, it's a three-dimensional data, but again, for a population level. And that sweet spot is really unique because we do quite a bit of these. We have about 100,000 volume CTs or scans of these patients, and we're trying to understand what comes out of it. And the interesting thing is that as cardiologists, we look at one number. Imagine this whole 3D CT scan, we get one number out of it, and we give it to the clinician and the patient and say, this is your risk, right? This is your calcium score or the plaque score that we can identify. But you can imagine we're ignoring 99%. This goes back to this 1% use. We're ignoring 99% of the information that's embedded in the CT scan. So early in my career, I kind of started to think about how can we milk this data for health insights so that we can create a better, not only risk prediction for heart disease, but other conditions. And I'll show you some examples of this. This is an example of two patients that have very, very similar, and this is the limitation of this score that we can come out of it. These are two patients that have their same age. They have very similar score. You can see 205 and 204, very, very similar scores. But you can see that they're very different in the spatial location of the plaque. They're very different in terms of which vessels. You can see A, B, C. These are three vessels, while on the right side had one vessel. And this MACE is major adverse cardiovascular event. Think of it as a heart attack. This patient on the left side had a heart attack approximately a year later. This patient on the right side had no heart attack. And yet, we're treating them the same way. When we take these scans, this is what gets reported in our clinical report. So the question becomes is how can we contextualize this result? How can we identify, how can we milk this information to help us modify our treatment strategies from a population health? So what we do is we started to think about the plaque itself and not just taking a summary, somewhat arbitrary summary of that plaque, but we take an actual biologic plausibility. We identify these plaques in 3 dimensions. We identify the centroids and link them and so on and so forth. But ideally, what we extract is quantitative information. In the era of digital health, I think this becomes a really unique area of discovery because instead of getting one number, now we're getting these quantitative metrics. We call them radiomics. Beyond plaque, we also have other organs. So from this one CT scan, we can extract all these different types of fat deposition. And in clinical medicine, what we use is body mass index, which is for the engineers, this is like extremely arbitrary number. This is a weight divided by square of the body surface area, basically square of the height. It's just somewhat arbitrary and doesn't capture the heterogeneity of fat, whether fat is embedded in the body and it's in the heart and so on and so forth. So these are all different types of fat that you can extract from a single scan. So the question is, can we take this fat, can we take the images from the plaque and quantify the radiomics, and then that gives us a digital footprint or fingerprint for different health conditions. And I can tell you every type of fat here has been linked with different health conditions. Abdominal fat that you see in green, for example, has been linked with a whole lot of GI stuff, whether it's hepatic liver fat. Periaortic fat has been linked with vasculitis, which can touch upon autoimmune diseases. Epicardial fat by itself has been linked with a lot of cardiac stuff. Everything here you see has been linked with everything in health, because this is obesity phenotyping that is opportunistic without spending a single penny on additional imaging. So we basically have all these pipelines that we've built that can identify, the size of aorta, size of the pulmonary artery, that gives us a lot of information, the size of the heart and the epicardial fat, and all these type of fats that we have, and even skeletal muscle, which touches upon what we call sarcopenia or muscle loss. And we have the idea of this is to create an explainable digital fingerprint of an individual that can then we take it and link it with whoever is interested in this. In this space. So for example, somebody is interested in dementia tomorrow, comes to me and says, hey, are there any, can we predict risk of dementia in the next 5 years? Absolutely, we can take all this piece of information that we have. We have the pipelines that are already applied. We have approximately 500 features or factors that are extracted from these CTs, and we can, in a day, we can actually predict risk of disease X or Y or Z. So that's where we're building things to build capacity for various conditions, and I would urge Houston Methodist, Rice, and everybody to really collaborate with us, because we're not cardiologists, we are data scientists that work in the cardiology space. We're applying some of this stuff. I'll tell you a little bit about some kind of micro, and this is an example of the only place where you can see the microvasculature, the tiny vessels that we have, without cutting a person open, is through the eye. And retinal images are available broadly. You can actually do them on your own by taking a picture with your iPhone. So it doesn't have to require a lot of technology, hardware. And more optometrists, like when you go get your eyes checked for lenses and so on and so forth, they are doing them right now. But they're becoming a sweet spot also for us, because we can move towards population, right? Instead of dealing with hospital patients that are almost always sick, we're dealing with population. So this data is unique in the sense that what we are able to do, microvasculature touches upon a lot of diseases, whether it's Alzheimer's disease or kidney disease or heart disease. And what we're looking at is really taking a different way of looking at these, where we take into account radiomics. We call them oculomics for the eye. We take these vessels, we segment them, we identify the vessels, the venules and the arterioles, and then we look into tortuosity, kind of explainable features, branching, tortuosity, angulation, density, and so on and so forth. And you can see that this is what we're creating out of this. And then we take these features, again, intended to be applied for multiple diseases. We take them and try to predict risk of conditions. In this case, we predicted risk of cardiovascular disease, which includes heart attacks, strokes, and heart failure. And we show that it is as good as a probabilistic risk factor model that we can plug in a lot of numbers in. And it also adds upon the probabilistic risk model. So this is something that we're trying to validate a little bit further in Houston Methodist. But we have the data, we have the models, and everything is ready and ripe for collaboration. Another thing that we often ignore, you go to a physician, you get blood work, and they tell you everything looks great. What does that mean? Everything looks great, right? So one of the major blood work tests that we do is something called CBC, complete blood count. This is very, very frequently done in outpatient setting for healthy people, and people do it for screening for random things. But generally, this is an ignored part, because the ranges, everything is in normal range, and everybody says it's normal. It turns out that the normal is not normal. There's actually a supernormal, and then everything else outside of that supernormal is not normal. It can indicate a variety of different health outcomes. So what we did is we took the CBC data at Houston Methodist and from a national data set and kind of variety of different health conditions, and we tried to create a biologic age from this CBC with differential and that nobody has done in the past. And what we show here is, this is a Kaplan-Meier for you who are not familiar with this sort of thing. We show that basically those who are, we can classify people who are all in the normal phase. We can classify them into resilient age, where their biologic age is younger than normal age or true age. And then we have an accelerated age, which is older than their age. And we have a proportionate age, where their CBC, the blood work, is telling us that their age is very similar to those to their normal age. And we show that those who have accelerated age are 9% of the population that are called normal, 9% of them, but they carry approximately 10-fold difference, 10-fold higher risk of having mortality, cardiovascular disease, you name it, all conditions across the board, because all conditions are age-related. And those who are resilient, you have a 50, 60% lower risk of having all sorts of bad stuff happening to them. So you can think of this. This is a normal data that you can reclassify into abnormal using simple machine learning that can help you allocate resources and define interventions that can happen at the population level, whether it's a behavioral intervention, whether it's statins, whether it's different type of things that can improve aging and move people from, and because this is dynamic, we can actually move people from accelerated aging to resilient aging. So this is something that's dynamic that can also incentivize patients to say, hey, you sit in this group, let's exercise for the next 3 months, let's repeat that test, and let's see whether you move in the right direction. So it's tangible, it's modifiable, and it's also impactful with respect to population health. And this is something that's, the vision. The vision is really for every individual patient that we have at Houston Methodist. We have their address. We have been linking them already with all these sources of images data. We also have all sorts of explainable, noise data, green space data, and then we create basically digital twin that links all this environmental data with all their health outcomes and the CT scan, for example, ECGs and other things that can merge all of this to create insights that are disease specific. So if you come to me and say, I'm interested in liver fat, let's combine all of this data that exists today to predict risk of kidney disease. Let's predict risk of going to cirrhosis and so on and so forth. And this is really the vision here, right? So you move from data, which we have a lot of right now, right, to wisdom. So you can build a lot of different pipelines around x-rays, CT scan, lab data, which I showed you a lot of examples on, neighborhood and exposome, but move it to risk prediction tools that can incorporate all of this data together. If we have wearables, great. If we have single cell omics, great. But generally, we are not gonna have that for a big population. And let's build all of these together into individual risk scores for patients and clinicians and health systems to help us navigate and allocate resources in the right place to improve population health. We have arguably, I don't know, maybe Ashu can speak to that, but arguably we've been the highest collaborators for Rice University from Houston Methodist, I think. But this is the number of students who have been, and the faculty, of course, at the top. We're collaborating with Ashu, Ashok, Guha, and Meng. And increasingly, hopefully, with Dr. Lee. And we have a lot of students that we've kind of figured out a way that we jointly supervise them for their graduate studies. We give them clinical insights, technical insights, and I act typically as the translator between the technical people and the clinical people so that we can enhance collaborations and being a catalyst for other collaborations. So a lot of these collaborations can actually involve other Houston Methodist faculty, clinicians, and so on and so forth. And we're working across different, when I showed you that image of the different modalities, we're working across different modalities. Of course, you cannot tackle all the problems at once. You can with foundation models, but now we're working from the explainable side. So we have people like Emmy, who is working on calcium score detection from scans that are not done for cardiovascular studies. Others are working on unique innovation with photon counting CT using deep learning and translation of segmentation on x-rays. We have another person, Yuhao, who's been working on environmental health connections. We have others working on echo, CT reconstructions, echocardiogram again, and ECG. So across the board, these students have been really instrumental in driving some of these pipelines But ultimately, really what the goal is, which I think we're very, very close, we're building blocks for this integration for prediction, phenotyping, and understanding health from a holistic, without spending an extra penny, maybe for compute, but not for attaching things to patients. And some of the other ongoing projects, I'm not going to belabor this, but just to give you a sense of what is possible and what we've been doing. We're working across ECG, cardiac MRI, CT, head CT, whole body imaging. We're working across the environment, understanding even air toxics that are emitted from unique resources or sources in Houston. We're working on the EHR space, really leveraging large language models to understand why do patients not go on some specific medications, what can we create in terms of insights, how can we summarize and decrease the note bloating. We're working on mathematical modeling of metabolic trajectories. And also we're doing some work on devices, but not the devices that we're creating. What we're doing is we really take data that exists in the EHR that links, for example, an ECG with a lab marker, an ECG with a blood pressure, creating that infrastructure that links ECG, for example, with the blood pressure, and take that model and apply it for devices. Because the same ECG that you can get from an Apple Watch, we have an example of it in our electronic health records. But the problem that we have is we don't have blood pressures for people who have wearable devices. So to solve this problem, we do this transfer learning process by creating insights, knowledge from Houston Methodist and transferring it over to wearable devices. And this is really, I think Khurram may have showed this slide before, but we have an infrastructure that is really deep in different directions that has not only the lab data, the tabular data, the notes, and everything from all electronic health record system patients at Houston Methodist, but we also have all the raw images and all the raw image data that comes along with it. We have all the environmental and exposome data. And the idea is really to create supervised, unsupervised foundation models that can really integrate a lot of these data sources for actionable health from population perspective, and also identifying at the individual perspective, individual phenotypes that can be allocated to different diseases and conditions. So I would like to thank my funding sources and happy to answer